Well, it is now 1 o'clock, so we will call the Alabama Commission of Evaluation of Services meeting to order. Marcus, will you please call the roll?
Yes. Chairman Orr. Here. Vice Chair Fillmore.
Here.
Commissioner Albritton. Here. Commissioner Allred. Here. Commissioner Carlton. Commissioner Coleman-Madison. Commissioner Gray. Commissioner Green. Here. Commissioner Sawyer.
Here.
Commissioner Sells. Here. Commissioner White.
Here.
Commissioner Witt.
Here.
Commissioner Poole.
Here.
And Commissioner Fulford. We have a quorum.
We have a quorum. We can proceed with our business here. We are going to adopt the minutes from the February 26, 2025 meeting. Do we have a motion? Second? All in favor, say aye. All opposed, like sign. The minutes are now approved. We will now move into reports and presentations. I'll kick it over to Savannah for the evaluation of mental health crisis centers. Thank you.
All right, I think that's working. Chair, Vice Chair, members of the Commission, thank you so much for being attentive to today's discussion on crisis centers. Our team completed a program evaluation of the 4 objectives that you can see on the screen. Now, I'm going to go a little bit out of order from our report, but I think it's really important to give you some context into the genesis of crisis centers that speaks directly to the quality and access to care. Before crisis centers opened, there was no place for individuals in a mental health, substance use, or suicidal crisis to go receive immediate specialized care. They'd have to go to the emergency room and wait until their personal psychiatrist or therapist was available, or just not receive care. Just by opening these crisis centers, the department has expanded behavioral health care in Alabama. When we talked to certified peer specialists, they said that if a crisis center was open during their time of crisis, this would have greatly benefited their recovery journey. Not to mention, these crisis centers were stood up by the department and the community mental health centers during the COVID-19 pandemic. And many of the crisis centers even opened a temporary location to start seeing consumers even quicker. So, throughout this presentation, you will hear me refer to the term consumers. And consumers is the proper term from the department that refers to individuals who receive crisis center care or services. So, we have talked about how they have expanded behavioral health care just by opening. But there are some barriers that could be addressed to continuously improve the quality and access to behavioral health care in Alabama. The first one I want to talk about is EMS drop-offs. Each crisis center has a designated spot or location for EMS services or first responders to drop consumers at the crisis center. And we found that although EMS services can drop off consumers, there are some financial barriers that could affect how often they choose to drop off consumers at the crisis centers. Medicaid and private insurance don't require drop-offs to be reimbursed at the crisis centers, and if they do reimburse those drop-offs, many times they're at the non-emergent rate. This could serve as a perverse incentive to continue dropping consumers off at the emergency department or emergency room, so they would get that higher emergent rate. So ACES recommends that the governor and the legislature should consider requiring Medicaid and private insurance to reimburse drop-offs at state-funded crisis centers under the emergent rate. The next barrier I'd like to talk about is transportation. Transportation is another potential barrier that consumers face, and we found that at times, consumers have difficulties making it to their next scheduled appointment after leaving the crisis center. Follow-up appointments are an essential part of the crisis center process, and consumers continue their care there and receive additional medication at the follow-up appointments. Even though follow-ups aren't necessarily under the crisis center control, follow-ups are one of the metrics that the department tracks, and they have stated is important to the work that crisis centers do. Addressing these barriers offers opportunities to continuously improve the quality and access to behavioral health care in Alabama. The next objective I'd like to talk to you all about is impact. What impact do crisis centers have on the communities they serve? In this iteration of the report, I cannot tell you the impact that crisis centers have based on the data that we received. For the purpose of continuous improvement, to measure impact, the data issues we are about to talk about should be addressed in order to properly isolate the variables, and additional data through a granular patient-level data set that speaks to impact should be provided. So let's talk about some of the issues we saw with the data. Two of the intended outcomes from the department and that they've cited is the number of individuals who have avoided jail admission and the number of individuals who have avoided emergency department admission. We found that the methodology used to track these two metrics is inconsistent and unverifiable. Take a look at the various ways that emergency department admission avoidance is tracked. As you can see, crisis centers collect this metric differently. This metric's also collected for different groups of people at different crisis centers. Now let's take a deeper look into the way avoidance of jail admission is tracked. None of the 5 crisis centers track this metric the exact same way. The various questions that are being asked aren't necessarily inherently bad or wrong. It's the fact that there's various questions and various methods to find this one metric. Additionally, we want these metrics to be at the least subjective as possible. Asking the person who dropped the consumer off if they would have called the police does not necessarily constitute or end in a jail admission or an arrest. So overall, for both of these metrics, the method that's used needs to be consistent and the same at every single crisis center, and it needs to be the most objective as possible to help the department set up the proper way to measure intended outcomes. The difference in methodologies is just one of the issues that we saw with the data that the department collects. The department chose a system of collecting monthly aggregate reports from crisis centers that surround a host of metrics: number of admissions, length of stay, triage encounters, referrals, follow-ups. And as is expected with most startups, these variables changed quite a bit. We found inconsistencies throughout these monthly reports. And that led us to look into deficiencies within the department's strategic control. Strategic control is the process for determining the extent to which an agency's strategies are successful in reaching its intended goals and outcomes. It addresses the gap between intent and realized goals. We just discussed 2 of the department's goals and how we're not able to measure them due to the issues outlined. But this is a summary really of 5 steps to gain strategic control. And it's clear that the department has the intent. Number 1, they identify their goals and objectives, but they have not created benchmarks, and there's not a reliable way to measure these goals and compare them back to the benchmarks and thus address the gap between intent and realized goals. So, to improve strategic control, oversight should be strengthened. There were multiple instances of inconsistent reporting, and there was also a case where one crisis center did not know how to report a metric, so they entered 0 for 22 months in a row without correction or intervention from the department, which showcases the need for additional technical assistance from the department and implementation of quality control metrics that ensure consistency. So to improve the department's collection of data to use these metrics to measure crisis center impact, the department needs to implement a quality control process. Adding in measures that ensure quality control will improve the department's strategic control and align itself with the SAMHSA guidelines. To address the inconsistencies in monthly reports, the department should provide clear reporting methodology for each data point and ensure that all crisis centers are tracking this the same way. Moving on to our next objective, fidelity. As we have discussed with you all in length before, fidelity matters. For this evaluation, crisis centers were measured against the model from the National Guidelines for Behavioral Health Crisis Care by SAMHSA. This guideline outlines minimum expectations and best practices, and we found that crisis centers do well operating with fidelity. Crisis centers are open 24/7, 365, For the most part, they are fully staffed 24/7, 365, which you can ask any crisis center director. That is no easy feat. They offer and receive first responder walk-ins and drop-offs. They do not turn anyone away for their inability to pay. Out of all the minimum expectations, there are only 2 areas where it's not always operated to with fidelity. And we do go over those 2 areas in our report, but in this presentation, I don't want to take away from the fact that overall crisis centers operate with fidelity. Our last objective that we are going to discuss today is cost. What costs are associated with operating the crisis centers? Crisis centers began receiving funding in fiscal year 21. Cumulatively, they have received $175 million of state funds. That's currently $42 million per year, $7 million for each crisis center. $6 million of that comes from the state general fund, and an additional $1 million comes from the special mental health fund. A potential issue of funding each crisis center equally at that $7 million rate is the variance in capital expenditures. This variance ranges from $3.3 million all the way up to $12 million. Capital expenditures drive the early cost of crisis centers, and this variance is whether a center has to build, renovate, buy a new building, or use an existing space. Additionally, the time it takes to become operational varies from 7 months to 28 months. And when you fund a center equally with nothing that ties funding to operations, a center could be non-operational while continuing to receive the $7 million. And in one case, in one crisis center, this was actually the case where this crisis center received 2 complete years of the full $7 million before becoming operational in their 3rd year of funding. It's important to note that this crisis center also did not open a temporary location to start serving consumers quicker. But I would like to point out that this particular center, faced unimaginable, unforeseen circumstances that may have affected their ability to begin operations. And although we understand that there are challenges to opening crisis services, the state of Georgia actually allows for reduced funding in their budget if crisis services start after their expected date. They use this provision in fiscal year 2020, where they reduced funding for a crisis stabilization unit that had a delayed opening. So we've talked a little bit about an equal funding model and how it doesn't account for capital expenditures and operational status. But an equal funding model also does not account for the differences in populations. I'm sure all of you know Alabama is a very diverse state, and each community has diverse needs. The current funding model does not account or consider differences in population size, services demand, facility capacity, or community needs. We found that some of our surrounding states do take these variables into account. They require centers to submit a local service plan that outlines demand, capacity, service, and need, and more of those variables. So ACES recommends that a needs-based funding model that takes these variables into account should be created. Also, there should be a differentiation between startup capital expenditure cost and annual operation cost. To end out our objective on cost, let's talk a little bit about utilization. As you'll see on the graph, utilization is a driver of cost effectiveness. There are large fixed costs that come with operating a crisis center. Think about the cost with being fully staffed 24/7, 365. It is expensive, and it's required whether crisis centers serve 1 consumer or 75 consumers in a day. When fixed costs are high across the board, utilization, which is admissions and length of stay, play an important factor in cost effectiveness. This analysis shows that from a cost perspective, more utilization typically equals lower cost per bed day, as you might expect. What I hope you take from this presentation is that crisis centers do well operating to the model. But there is room for improvement to remove barriers and improve data collection to measure the department's stated outcomes. With that, I'd be more than happy to take questions or pass it back to you, Vice Chair.
Thank you, Savannah. Do we have any questions? Sure.
Madam Chair, I would like to say that I do think that the report, you've done a really good job on the report, and I know this was a difficult report, not because the department that you was looking at, but this is a new, let's just say, a new way of doing business in Alabama in dealing with mental health. So, I equate this to a new business that we're starting up off the ground, and I expect to find some issues, just like we would with anything else. So, but I do want to thank you for your hard work during this process and presenting it to dumb down for me. I do thank you for that. I do have a question. Do you think HIPAA played a role in some of the data that you was unable to maybe get?
Absolutely. We had discussions with the department going back, I believe beginning February 6th, our first meeting with the department to talk about how to move forward with the data request started on February 24th, and it took a couple months. I can go over that timeline with you at a later date, but if you have any other questions, I'd be happy to answer them.
No, that's fine. Thank you, Madam Chair.
Any other questions?
I was going to
comments?
make a comment.
Sure.
I had previously recused myself from the conversation, but I really appreciated that overview because it gave me a much broader perspective of the outcomes of the review versus my reading of the actual report. I was a little stunned, quite frankly, in reading the hard copy report compared to your presentation just then. And just with that thought in mind, I don't know how or what we do with the reports in terms of sharing them, but I got a much more positive, I will just be very frank. I mean, I'm just, you know who I am. I'm being very honest. I got a much more positive from hearing your presentation versus the reading.
Absolutely.
And I just put that out there for consideration in terms of to whom or with whom is this report type shared. Because you've introduced something that was new to the state, a conversation I think I had last week, where we have great intentions with evaluation, but the real benefit of evaluation with appropriation is to present the evaluation projected outcomes on performance measures at the outset. So the agency knows what it is you seek to measure. What do you determine to be, satisfaction, whether it's impact or systemic, just what is the agency is expected 2, 3, 4 years down the line. They were obviously trying to follow whatever metrics and model you mentioned, Samson, that they could. So that's why I just say, for anybody else like we have like this, who engages with us through this process of who we say we are, how do we prevent the appearance that, you follow what I'm asking?
Yes, ma'am.
And I yield to you because I read it, and obviously with my knowledge of the system and what, I was going, whoa. But hearing your presentation, I was,
Absolutely.
Okay.
So part of the ACES process is to have a stakeholder work group meeting.
Okay.
And that is where we come with the department in hopes to work together, cover things that may be factually inaccurate. We are all human. We rely on each other to make sure that those things are corrected. Talk to the department or the agency that we're evaluating and get their opinion. And after we had that meeting, there were several things that we changed. Now, the things in our report were still important that lead to strategic control and that sort of thing. But overall, we say they operate with fidelity. And any program, especially one newer in their phases, they're going to have goods and bads. But it's not a bad thing. It's we're working together to improve that agency. We're on the same team for taxpayer dollars. And I also want to mention that part of ACES's process in our engagement conference is to discuss objectives and provide those objectives to all members in attendance and follow up the next day with an email that includes those objectives.
so your outcomes of the discussions relative to how you go forward, were there any that there was consensus in that process?
The outcomes of the stakeholder work group meeting, Absolutely. The department raised some concerns, and we took them into account and softened some of the language that was used and provided more detail in areas that they asked us to.
I'll chime in there too. No, there wasn't full consensus.
Okay.
We obviously had disagreements on some of the things that were in the report, and I think the commissioner and I, even said as much in the meeting that we're just not going to come to agreement on it, and that happens. But our goal from this evaluation is, and I understand the read and I understand the context of that, but our goal is to always focus on continuous improvement. And there are ways that we saw that could be improved, and we pointed to those, and we pointed to why those things exist. But the emphasis and the focus is on continuous improvement. And that's where we want to direct this conversation, especially post-evaluation and into the future, is to look at the long-term impacts of what we're doing in this space, and how best do we position ourselves to measure that impact long-term.
Kathy, it also speaks to, obviously, Marcus circulated today the letter that's an attachment on the report that says the report is preliminary.
Okay, I missed that.
There's not conclusive data
Oh,
to
okay.
speak to what the outcome
okay.
of this is.
I'm sorry, I missed that.
Recognizing that crisis centers are in the infancy of their
Okay.
development.
No, I appreciate that. And I wondered, Marcus, I appreciate that as well, similar to the comment about impact. Because at the outset, it seemed as though the direction we were going in is the impact it has on people being diverted from jails and hospital. And when we were immediately challenged with the access to the public health information. So I'm assuming that's the next kind of the continuous improvement that the commission with the department we're looking at when we talk about overall impact.
Yeah, I think that that is certainly something that needs to be pursued. I think it is very difficult. But it's not impossible. I think that you can work with the relation. We've seen this in other organizations and other challenges that we've had in evaluation. It's not an easy lift, but you got to have people willing to go out there and do the work, and we're dedicated to doing that. So we can work with hospitals or public health and their discharge data that they're collecting now through, I think it's the medical association, and then work with. We reached out to these folks, and it takes a little bit more time to develop those relationships and trust and all of that, but it can be done. I mean, it's difficult, but it can be done. We're willing to go to those links if the commission would like us to.
Thank you.
Any other comment?
Just one more comment, and I'll be quiet. Well, for this round, there's not a one of us sitting around this table or in the audience today that does not want to better themselves, that does not want to better the mental health care in the state of Alabama. And I think that with this process that we've done today, we know that crisis centers are a very important piece of that moving forward, and they're going to play a big role in the state of Alabama. I think there's 6 now. I think there's 11, if I'm not mistaken, that we're looking at putting on in the state of Alabama. So anytime we can offer suggestions and improvements and work with the department, we all encourage that. But I think everyone around here wants to look how we can better ourselves and how we can deliver the care the citizens need.
Absolutely. Thank you.
So I think I make this point at every meeting. Data, right? If you want data to be able to measure this or any other program, you absolutely have to require the agency to provide the data. It's an appropriation. You can tie the funding for whatever you're doing to reporting language or to a report that outlines the data that you, the appropriators, Chairman, we had a similar discussion earlier. Whatever data you need to be able to do, because it doesn't matter if it was ACEs, it doesn't matter if you hired somebody off the street, the first thing they're going to have is data. Otherwise, it's their guess versus what the agency's interpretation of what their intent is. So if you don't tell them what to collect and report,
They aren't doing it.
they're not going to do it, and you're going to be, trying to figure out what they actually gave you. So But I will say, I enjoyed the report. I think, too early to be able to give a broad scope answer to the question, but I think it did outline some very interesting points. I mean, the equal funding model question is certainly a question to ask. That was very interesting to see that also. And I don't want to be visited by anybody, but I was kind of interested to know that they don't consider local funding in determining how much each one of the centers get, because it seems as though there are a couple of those that receive local funding. That is a part of the component on the ARC distribution money that we do in the education budget. But again, I don't want to get into that. I was just making that point. Thank you.
I don't want to jump on the bandwagon and always agree with Kirk, because we don't always agree. But I will say in this case, he's 100% correct. If we're going to hold these agencies accountable and we're going to write reports that don't put them in the best light, then we need to give them what we want them to do at the beginning and not halfway through the process and punish them for it. Putting that language and reporting language in the appropriation bill would solve a lot of these problems. And so maybe as we are funding things in the budget, the ACES group, as things are y'all are over in the State House too, as things are moving along, you can make suggestions on new programs. Because I really don't think it's fair to the agencies for us to come back and slap their hand later because they're starting a new program. So that's my thoughts. Thank you.
Any other thoughts? Yes,
Yeah.
Dave.
Yes, ma'am. So we need good data. We need to decide what do we want? What are we measuring? So maybe unique visits or unique admissions for how long, occupancy rates, that gets to cost per bed. Also outcomes. Just asking somebody, well, does this keep you from committing suicide? That's not going to cut it. But maybe, where was the person referred? What was the ultimate outcome for that person? So if we come up with ideas that a very good staff agree are good criteria, and a very good staff agree are good criteria, and our appropriators, who of course are great, decide on what we want to measure. Make it clear the outcome. Absolutely. Get it out there front and then measure it and hold them to it. Because we don't know if we're getting good bang for the buck. So let's decide what we're going to measure to find that out. And decide fairly quickly where everybody agrees that, yes, we sing Kumbaya, these work, we agree, that's what we're going to measure, you're going to be judged by it. That makes sense?
Don't look at me, but I think it makes sense. Dave, I think what's missing is, where does that type of criteria evidence exist? When you looked at the SAMHSA model, did you find in it those types of, ways to measure impact? That's the model the mental health system apparently has used with all of its programs, where this one falls. Did you find in that model how they tied, you follow what I'm saying?
I am.
Where you could measure actual impact, which is what it appears this commission ultimately looks for. What impact did it have on the population it was intended to serve? So what did that metrics tell us in response to Dave's and others' questions? How do you tie those types of outcomes? Because we don't know.
Absolutely. So the SAMHSA guidelines, again, has a host of metrics that they recommend that the crisis centers collect and keep and evaluate. And they do have some different ways that they talk about the best way to evaluate. And on a side note from that, which it all starts, that list of data points, metrics that they're collecting. It's not that the what is wrong, it's that the how could be improved. And so the different things we talked about, like having the same methodology across all centers and ensuring that they're all doing it how it's intended, how the department writes the data dictionary, and that if there's anomaly like a 0 for 22 months in a row, that gets addressed. But I would also like to say, part of our process is looking how other researchers evaluate similarly suited things. And so we had a few different meetings with different researchers, and there is a researcher out of Texas who actually looked at the impact of their crisis centers on future jail arrest. future arrest or admission into jail. And they used crisis centers as the intervention and followed that person through a data sharing agreement that was with the jail and the crisis center. They shared data, de-identified it, sent it to the research team, and then that research team followed them in longevity to see if they went to the crisis center, were they less likely to have an additional arrest than a comparison group of similar demographics and that kind of stuff. So that was our original intent with this report, is to do something similar to that. And it all starts with getting granular patient level data, and we weren't able to do that for this report. But to continuously improve and get to be able to measure that impact, that's one of our objectives. We could, if we get that granular level data, then we will be and the methods are the same across the board. We'll be able to use that and then further look at if there's additional emergency department admissions or jail admissions.
And Commissioner Sawyer, there is guidance from the national guidelines for crisis care systems that suggests that you ought to have a central repository for this information, and that just simply doesn't exist within the Department of Mental Health. Yeah. So you're reliant on each individual center to report information, collect information, and that opens the door for a lot of variance.
And please understand, I'm only saying that whatever the expectation would be after this deeper dive, that we come forth with some very clear recommendations that the department could use that really clearly states what is it we're going to measure, how, and then come back. So everybody, we've done this legwork. Now it's time to say which model are you going to look at, Texas, and let it be your guide coming from the recommendation of ACES, or are you going to follow the SAMHSA guide? I think that's the decision ACES has to make. Whose recommendations that impact these types of service models in the country are you going to follow and recommend to the state of Alabama, is my point. Texas is one. We've just said Alabama falls under the SAMHSA model for all of its mental health programs. So are we going to adopt SAMHSA, or are we going to go to another model? That's all I'm saying. Right. And whatever it is, articulate it clearly, and then have the agency report periodically, quarterly, however, on these data metrics.
Yes. So the Texas model, or the Texas research, isn't a model, and they do still follow the SAMHSA. And we're not suggesting replacing the research and evaluation that Texas did with replacing that at all. The SAMHSA guidelines are great about what data points they should be collecting. We just got to get all the crisis centers together and the department together to say, how do we do this? That's the least subjective and the most consistent, and what quality control metrics do we have in place to ensure consistency?
Chairman Albritton.
Thank you.
Yes.
I feel a little bit put upon. Sounds like the legislature needs to be a little bit more clear about what we want. I don't think it's our job to tell you how to do something sometimes, in most cases, but I think we need to be clear about what we need. I think we can remedy that. I would encourage any advice or suggestions of what that may entail. We'd welcome that, and we got plenty of time between now and there. But on the whole scale, I think what we've done here is a good government model here. By that I mean we've stood up a program in difficult times. We've brought it to fruition. And then we've taken a second step of taking a look at what the weaknesses are, what needs to be done, and now we need to move forward from there. I think on a whole, we've done pretty doggone good work as to trying to fix a difficult problem in the state. Mm-hmm. And when you try to fix problems, you run into contentions and difficulties and stepping on toes. That's just part of the nature of work. Now we've got to figure out what we need to do, and then figure out how it's to be done so that we can make sure that we accomplish what we want. Does that make sense?
It does.
I think ACES has done a great job with them bringing this out. I think Department of Mental Health is when he brought this program to us to stand it up, and we took those suggestions and followed the council there. Now let's see where else we can move forward to continue to improve.
Well, we will wrap up this report from Savannah with Chairman Albritton's comments. Yeah. We will now ask Commissioner Boswell. Yes. Why don't you put?
I just wanted to say how much I appreciate the comments. I've been listening in closely and a lot of wisdom around that table. Good thing I'm not there because I wouldn't count myself in such a great group, an august group. But, this brings back to me the kind of deja vu all over again with our situation that we had with the Helping Families Initiative. And I just wanted to remark the similarities that we have with our Helping Families, where in that program, they're working through the local DAs. They don't control the DAs. They do have some money that we appropriate to Helping Families, but each program is operated by a very autonomous district attorney organization in that circuit. Similarly, we have a situation where the Department of Mental Health is working through the providers in the various areas of the state, each provider responsible for their particular territory, but they're not directly under the Department of Mental Health. They're not state employees. They're nonprofits with their own boards and some autonomy and independence. So I have a sympathy for the difficulties that the department faces in executing some of the desired outputs in the coming days and in the past days. And I know data collection will continue to probably be a challenge as you have a lot of different organizations with whom you're working. You're going to get somewhat of mixed feedback, and the better we can bring them into conformity and consistency and in that data collection process, the better. But the department is operating at a disadvantage, even though they hold the gold. It's still somewhat a disadvantage as opposed to having each crisis center, the mental health operation at the local level, being under the auspices or being part of state government directly. So appreciate the work the department's doing. I appreciate the ACES team and their efforts, and I will be quiet and yield the rest of my time for the rest of the meeting. Thank you.
Chairman Orr, thank you. Obviously, we now have Commissioner Boswell, who's going to speak directly about the Department of Mental Health in respect to these crisis centers. Commissioner, you have the floor.
Thank you very much. I'm really excited to be here today. Thank you to the commission and thank you to the ACES staff. They were very collegial and very respectful and spent a significant amount of time with our community mental health centers that operate crisis centers around the state. I did want to take this opportunity to introduce you guys to the fine executive directors who stood up 6 crisis centers in 5 years in the middle of COVID. So I'll ask them to stand. So we have with us today Turk Schlesinger from Alta Point, Melissa from Spectra Care, Jim from JBS, Donna from Carastar, and Karen from Tuscaloosa. How could I forget Karen in Tuscaloosa? The only person not with us today is Jeremy, who operates the crisis center in Madison County in the Huntsville area. So, want to go ahead and get started. When we stood up this program, and you've heard a lot of this today, the mental health program in our state was in desperate need of a transformation. We were really struggling, and actually on the side that says before on the screen, Savannah covered part of that. Really, in our system, the only way that you could get crisis services is really if you went to the emergency department or if you went to a private hospital. The other issue is more often than not, when people were in a behavioral health crisis and didn't know what to do, they dialed 911. And the only two folks who can come and get you are EMS or law enforcement, and sometimes both. The only two places they could take you before crisis centers is either the emergency department or to jail. And so that was the situation we were in at that time. We also had separate services for mental health and substance use. So those services were not integrated during that time. We made a major shift, a big pivot, to say what is going on around the nation, what is the best practice that we can look at and say, what's going to serve the citizens of Alabama and keep folks with mental illness out of jails and out of emergency departments. And that's when we decided to stand up crisis centers in our state. 24/7, 365 days a year. Those crisis centers are open. So now when you're in a mental health crisis, you don't have to dial 911. You can go directly to the crisis center. You can dial 988 and be directed to the closest crisis center. You can walk in, your family member can bring you. So now there is an option for the citizens of Alabama to be able to have their mental health crisis dealt with by professionals who are there every single day of the year. We also knew when we stood up crisis centers that we were headed to a bigger transformation called Certified Community Behavioral Health Clinics. It's a national model, it is an integrated care model. This particular administration is extremely supportive of CCBHC. We were one of the few southeastern states who competed for and received a grant for CCBHC demonstration grant in collaboration with Medicaid and SAMHSA. Okay, this is going to be challenging. We did have an evaluation. For those of you who don't know, I have a master's degree in social work administration with a specialization in planning and program eval. So we started this process with an evaluation that we thought was a reasonable one. It started with a request for proposal. And I will say at that time in our system, requests for proposals were unheard of. We kind of had this funding model where when we got some money, we distributed it equally across the state. That didn't work out well a lot of times. That didn't help anybody. What it usually meant is nobody got what they really needed. They just got a little bit of money to try and do things a better way. So we started with an RFP that really defined the services, defined the funding model as well as the services. We monitored that to make sure that those services were offered to the fidelity of the model, which you've heard a little bit about today. And then we also established performance measures that are the national standards through the monthly reporting and data collection of performance measures established through the set of national guidelines that you've heard discussed today. The request for proposals, the first round, we had 3 community mental health centers. Again, this was in 2021 in the middle of COVID. That these 3 in particular stood up services almost immediately. So those 3 centers were Wellstone, Caristar here in Montgomery, and Alta Point in Mobile. The following years, for anyone who did not score over an 80 on the RFP response, they had to resubmit. So we had a couple of centers that had to resubmit a response to the RFP. And since then, we funded JBS in Birmingham, Indian Rivers in Tuscaloosa, and Spectre Care in Dothan. Crisis Center service definitions and fidelity to the model. So we were adamant about sticking to the fidelity of the model. At this point, and under the previous guidelines, voluntary admissions were the primary focus. Under the new guidelines that have recently come out, there is discussion around 72-hour hold and civil commitment beds as a part of a crisis center. That's a conversation that we'll be looking at going into this next year. Also, there are multiple different levels of assessment in that crisis centers that have to be done by various professionals, including nurses and psychiatrists. Temporary observation is a level of care that is 24 hours or less, and then extended observation is 5 to 7 day stay in essence, a crisis stabilization unit. So basically inpatient care. So they are providing inpatient care just like a hospital would in a community setting. So in terms of the monthly data monitoring, since we started this, every time we've done a budget presentation, we have presented our national standards. You can see that the very first time, it was not very sophisticated. We tracked the evaluations, and then we tracked follow-up and readmissions. Follow-up is very important. You heard Savannah talk about this. And so that's something that we track that really does have to do with the quality of care and making sure people are getting to that next appointment. In the very beginning, the rate was 79%. And then, of course, we monitor readmissions from a quality standpoint, because if you're coming back to the crisis center over and over again, then there's something that we're not doing right in the crisis center to make sure you're getting triaged the way that you need to. So this is the data for 2022. And I'm going to go through this part pretty quickly. Some of you have seen these graphs more times than you would care to see them. In 23, we were at 5,453 evaluations. 24 was our best year yet, because we served 8,260 individuals in our crisis centers. And if you went back and did a cumulative on 21, 22, and 23, it would be 8,000. So in 2024, what you see over time is the longer the centers are open, the more people that they're serving. And I'm hoping, I cannot see that screen. Hopefully that's the 22,000 evaluations, is it? Or is it still one more? Okay. My vision is not that good. So cumulatively, through July of this year, the crisis centers have seen 22,297 people. For presenting symptoms, you can see the number of individuals who showed up at a crisis center whose presenting symptom was that they were in a suicidal crisis. It's a little disturbing, honestly, to me that that number seems to not be very important. For me, it is very important. Even if that means when they're on admission, you simply ask them questions and that comes out to be they're in a suicidal crisis, that's pretty important, in my opinion, as the mental health commissioner. Psychosis is another area that is one of the more challenging issues. Someone who is in psychosis is either having hallucinations or delusions and not in the same reality with us. That makes it very, very dangerous, honestly, for family members and for law enforcement if they engage in that with them during that time that they are in psychosis. So having that many people who showed up at a crisis center instead of having a negative engagement with law enforcement or their family member is really, really important. What you can see in this slide as well is that the follow-up increased. So in the very beginning, it was around 79%. We are now at 86% on the follow-up. And then the readmission rate has gone up some. Part of that is we're seeing more individuals. If you track back and looked at presenting symptoms, we're seeing more individuals with substance use disorder, and therefore those individuals often do come back more often than individuals with a mental health issue. The other thing I want to say to you is this is all part of a system of care, the Alabama Crisis System of Care that we've been building over the last 5 years. The first part of that is someone to call, which is our 988 crisis line. We do have mobile crisis teams in rural areas. Those were actually funded in 2021. I believe Senator Albritton, there was some negotiating about having some mobile crisis teams in rural counties. And so originally there were 5 mobile crisis teams that are still out there functioning today. The somewhere to go is the crisis center for someone who's having a serious mental health crisis. I did include the numbers for 988 because 988 is critical to making sure people are not calling 911 and not getting diverted to the ER or to jail. We stood up in the middle of standing up crisis centers, a 988 line. That was no easy task. The center that was discussed about taking a long time to stand up, they have been operating a call center, and they're one of the most productive call centers we have in the state, the call center in Dothan. And so, yes, their crisis center wasn't open, but they were delivering services, and they were also doing mobile crisis teams during that point. So in Alabama, since July 2022, we've had over 136,000 contacts through 988. Our whole goal is for people not to call 911, not to have to go to the ER or jail, to have them know where the resources are available, to walk in, for their family member to bring them. That's a very important part of the crisis system of care. And again, all of this is really moving to an integrated care model known as certified community behavioral health clinics. To be competitive for the national demonstration, we had to have crisis services in place. So we had a plan of where we were going. We knew where we're headed, and we knew we needed to stand crisis services up to be able to shift to this much better integrated care model in the state of Alabama. So for the ACEs evaluation, the engagement letter that we received outlined that basically the evaluation objectives will encompass the effectiveness, efficiency, and capacity at the crisis diversion centers. We really didn't know much more than that until our stakeholder meeting, or until we saw the first report, which was on August 8th, where we learned that the purpose of the evaluation was to answer the 4 questions that you see on the screen. So there are some things in the findings that we agree with. Obviously, we've talked about the fidelity of the model. The funding model was based on specific levels of care, and so it was really, really important for those levels of care to be present. If we're paying you at a rate that is appropriate for an inpatient bed and you're only doing 23-hour observation, then you're not operating to the fidelity of the model. And so the fidelity of the model was a big thing for us, to make sure that the crisis centers were following what was in the RFP and they were operating the levels of care that required that level of funding. The capital expenditures really were all over the place. Different community mental health centers. Some community mental health centers raised money in their local community to build their facilities. Some did receive funding, capital funding from a county commission or a city council. It really was up to the crisis centers to have to figure out how they were going to come up with the capital expenses. So some used some of that in the very beginning. So it really is an accurate statement to say that it was kind of all over the place because we really left it up to the crisis centers to figure out how they were going to fund their capital expenses. It also is true that the crisis centers opened in temporary locations. So you had capital expenses associated with the temporary operation, and then you had capital expenses associated with opening the crisis centers. So 4 out of the 6 actually opened in a temporary location before they opened their main crisis center. In fact, Karen just recently opened a beautiful brand new facility in Tuscaloosa. What that means is they were operating with fewer beds during that time when they were open in the temporary location. So some of the data issues that have been talked about really do have to do with a startup organization that is continuing to transition from a temporary location to a permanent location and having to hire staff and do all the things that are required. For most of the centers, as you've heard, there are a lot of fixed costs to operate 24/7. You have to have a whole lot of staff. So we agree with those recommendations. We don't agree with the following recommendations. We don't believe that there is deficiency in the ADMH's strategic control. We have operated to the evaluation plan that we established. Do we have some data issues that could be cleaned up? Absolutely. But we held our community mental health centers to the fidelity of the model. We held them to expenditures that we felt like were important to the overall operation. And so we really disagree that we don't have strategic control over the crisis centers. The EMS issue is interesting because there are EMS folks who drop off. There was only one EMS provider that was interviewed. If you look at the front of your report, you can see the name of that provider who's in the Birmingham area. So, you know, there are EMS providers that drop off at our facilities. There are EMS providers who get paid by Medicaid a non-emergency rate. There are EMS providers that could get paid that rate that probably don't know that they can be paid that rate. And then you have the EMS providers that want the emergency rate because that's a lot more than the non-emergency transportation rate Medicaid pays. So that's a good policy issue. It's an important conversation, and we had some good discussion with ACES about it. It just doesn't speak to the evaluation of the crisis centers. It really isn't a part of the scope that was outlined for the crisis centers. We think it's an important conversation. We just don't necessarily think it relates to the crisis centers. The equal funding model, again, we operate a rural, right now we're operating a rural pilot. Actually, a couple of them are in process. That's in a different line item than the 6 crisis centers. So we have mobile crisis teams. We have a rural crisis pilot in South Central Alabama that we have been working on for 2 years. We also have another community provider in Southwest Alabama that is looking at a combination center in that part of the state. Those were not really part of the conversation because that was not, again, in the scope of what ACES was assigned to do. So there are some considerations. The original model was based on a regional model. If you look at the 6 crisis centers who are spread out across the state, we originally did an RFI and asked all the regions to come together and figure out what services they needed in their region. And that's really where a lot of the decisions around who's going to apply first, how is this going to work, where are the greatest needs. We did, I forgot how many rounds, and we actually finished them before COVID hit, of stakeholder engagement meetings around the state at the very beginning of this process. So we had sheriffs, we had probate judges, we had hospitals, everybody at those stakeholder engagement meetings that helped form how we were going to issue the RFP. The equal funding model, too, is we're not giving rural mental health centers necessarily $7 million. The current model in South Central is at $4 million, $1 million of that from us, and then $3 million that was appropriated a few years ago. And then those centers also are using something called MyCare iPads in their communities where they're handing an iPad to the law enforcement officer so that if they run into someone who is having a mental health crisis, they can immediately be in contact with the community mental health center and the mobile crisis team. Honestly, the utilization data we were pretty confused about and had a lot of questions around how that data was calculated. Not sure which data elements were used to calculate that. And so we just weren't sure. And we discussed it a little bit at our meeting, and some of that is time sort of ran out. We had those discussions. There were some feedback, but we really are not absolutely sure about where the utilization data comes from because we know our crisis centers are at capacity, pretty much at 90% capacity all the time. people in the extended observation beds, people who are in the temporary observation beds. And so it's very confusing to us that this data is out there because that doesn't line up with what we know to be reality. The only center that wouldn't be in that boat is Spectre Care, who really only opened in February. So Spectre Care's numbers, I think, were not even included in the utilization data for that reason. But our JBS in particular in Birmingham is pretty maxed out in terms of the number of people they're serving. So with regard to the recommendations, we do think obviously the data could improve. The data, as we looked at it, there was pretty much a pattern where the first 2 years we had some data errors. That was true for Alta Point and Wellstone, and then the data became much more correct over time, and the same was true with JBS, where the first year of operation and first 18 months of operation, there were some challenges with the data, and then that data sort of cleared up over time. We agree that there could be some more quality control put into place. We have one person, I think he's in the room, Anthony Reynolds, he is, who is our crisis center guy. And his focus is primarily on programmatic data, but there are some things we could do in relation to the data that would absolutely improve things. The recommendation require Medicaid and private insurance to reimburse EMS drop-offs at the emergent rate at state-funded crisis centers. We think that's a great idea. We just don't think it's within our scope to do that. That's a policy discussion that I think is great for the commission. It is an issue. I absolutely believe it is an issue for some EMS providers that would rather drop off at a hospital because they're going to get paid more. I mean, they're operating a business, so of course, if they're going to get paid a high rate for the ER drop-off and a low rate for the crisis center drop-off, but we do have quite a few EMS providers that drop off at crisis centers. Create a needs-based funding model. Again, we are creating a needs-based funding model, mainly a difference between an urban and rural model that we've been looking at for the last 2 years. Some of our folks have gone to Oklahoma a couple of times. Oklahoma's come here a couple of times. And so we believe there is a needs-based funding model. Probably isn't evident if all you're looking at is just the 6 crisis centers. That would be more evident if you were looking at the mobile crisis teams and the rural crisis model. I think it's really important. We wish we had differentiated better between startup and annual operations. We wish we had done that on the front end. That was one of the lessons learned, like, okay, we really should have set some more parameters with that particular issue. And last, the challenges. I think the challenge for us was there was no evaluation design in the very beginning that we were aware of. Maybe there was an evaluation design that ACES was aware of, but all we had to go on was the letter, the engagement letter, and then the report that they sent us on August the 8th, where we learned that they were looking at those 4 questions. There was a lot of time wasted, frankly, around, and it was extremely frustrating for everybody involved around protected health information. You know, where we finally got to is to explain that even if we could get everything between the attorneys at all the community mental health centers and our attorneys, because they keep some of the data, we keep some of the data, if we could have gotten them all to agree, ACES still wouldn't have been able to accept that data because you don't have a privacy officer, you don't have a security officer, and you don't have an institutional review board. And so those are the things that if we were going to give you protected health information, and we think that's really important for the commission to understand, because if there is a data breach, it's the commission that is going to be the one who has to write the check for the data breach. And so as y'all discuss that, as a commission, I think it's really important to understand what is required in order to even accept protected health information. And that's a discussion, again, we had with the ACES staff. There really wasn't enough time to go back and forth with the data. When there were data issues that arose, there really wasn't enough time to go back and sit down and say, here's what we think that data means. Does that data really mean that? Is this a data error? Or I feel like the staff would have been willing to do quite a bit more back and forth and really desired to understand what the data meant and worked really hard to try and make that data meaningful. And the other thing is just the context, which I think has been raised a little bit. What you heard from Savannah today was really, really positive, and we appreciate that. But if you look at the report, it doesn't necessarily have that same kind of positive tone to it. So with that, I'll be happy to answer any questions.
Commissioner, thank you for joining our meeting today and taking time out of your busy schedule. It means a lot to us that you would be here. Obviously, you are the expert in this field. I know that some commission members will have some questions, but thank you for being here.
Sure.
Madam Chair, thank you. Commissioner, thank you again for being here. I will echo her, and I certainly am a fan of your crisis centers, but mentioned twice in your presentation was the engagement letter. You didn't know what you were looking for or ACES was looking for, but yet in your presentation it says the evaluation objectives will encompass the effectiveness, efficiency, and capacity at the crisis diversion centers. And then your questions was, with ACES, what impacts do crisis centers have on the community they serve? How have the crisis centers improved the quality of access to care? Is that not the effectiveness and efficiency?
Sure, it is.
Then you knew that's what they were looking at, correct?
We knew that on August the 8th.
Okay, I would like a copy of that letter because I want to get a copy of the letter to see what is asked, that we're asking of the departments to know that the information that we're seeking that you have when you get it and that we're expected to look at. I would like to see a copy of that letter if possible.
Commissioner, if I can say,
Sure.
It's standard operating procedure for us to share the objectives with the agency or program in the entrance conference.
Yeah,
and we did that, and then we followed it up with an email that summarized that discussion. So that was discussed and that was shared.
Okay, I'd like a copy of that to make sure, because it seems like oftentimes when we get state agencies in, they throw their hands up. Well, I didn't know that, and I'm going down to contract review and hear a lot of the same issues here in just a moment, I'm afraid. Second of all, the one that had the money that wasn't stood up, that was able to carry the $6.6 million, are they carrying that in their bank account still, or was that returned back to the Department of Mental Health, or is that just in their fund for future advance?
I think the report spoke to that. They were operating other services, including the 988 call center, which is part of our crisis continuum, as well as operating mobile crisis teams until they could, so that they could get services out before they had the crisis center open. They're one of the centers that immediately, when they opened, they started taking individuals because they spent a lot of time recruiting staff. Many of the other centers did not have that luxury during COVID. They had great difficulty recruiting staff. And so they are spending those funds appropriately in operating their current crisis center. I don't know from, and Marcus, you may remember, that money is not sitting in the bank account as far as I know, but I didn't dig deeper into that.
We just looked at the financials and saw that those were funds that were unspent. They may be obligated for future expenditures, but they were just unspent.
Yeah.
So they were
Obligated. Yeah.
possibly obligated expenditures then
Yeah.
for that. And then also my last question would be the needs-based budgeting, and certainly I'm a fan of that. And you mentioned looking into Oklahoma. Why not Texas and Georgia that already has the program up running? And I think it's called, you'll have to forgive me. I don't remember exactly the name. I had written it down, but it was the Georgia program in Texas that they're using now.
So the original model was based off of Georgia. We were looking specifically at Oklahoma for a rural model, for a pilot for our more rural counties. So we have several counties that are several community mental health centers that have pretty much only rural counties. So our interest in Oklahoma was around a rural crisis program rather than in a large city where you need a lot more beds and a lot more capacity.
Okay. Thank you,
Thank you.
Commissioner.
Yeah, and I need to correct, Savannah just handed this to me. There were some notes from the entrance conference where they listed those questions. We just missed them, so. Okay. Yeah, she did great following up.
Thank you.
Timely, fast.
Any other questions?
I have a question, which is a clarification. Thank you, Commissioner. I guess others in the room, I was excited about one thing I thought I heard. The 72-hour hold provision that's being considered for the crisis centers. If I'm understanding correctly, if we are able to prevail with that provision, that would allow us through the crisis centers to serve people who are not willing to volunteer. I always said, Dave knows my positions about crisis centers for people with mental illnesses who are in crisis. Typically, they're not capable of volunteering to go into treatment and care. So that was always one thing that was problematic. So I'm just hearing the 72-hour hold. If that's what I'm thinking it will do, allow us to serve those individuals who are not willing to present voluntarily.
So that's just a discussion. Probably all the
Okay.
community mental health center directors are freaking out
They're
right about
shrilling,
now.
okay. Well,
Because
I'm
my-
excited, I will tell you that.
My comment was that it's in the new guidelines.
Yeah, I know.
So previously, the guidelines only allowed for, or voluntary.
Yeah.
So someone who's willing to go.
Yeah.
There is one crisis center because of local legislation that does do 72-hour hold.
Okay.
And as y'all know, there's a big conversation going on about civil commitment beds and the lack of civil commitment beds. So we anticipate having many conversations with everyone involved in the budgeting process to make sure that we are maximizing the use of those beds. I didn't commit to anything, y'all, I promise.
And you know, I ask it, thank you.
Thank you, Commissioner, for being here,
Sure.
and also for providing us the professional response that comes in. It gives us both sides and able to put these things. But I would like to call attention to one slide that you had before, and that was the 5 recommendations that were there. And you had, I think, of the 5, 3 of them you put agree. And there's 2 that seem to be disagree. One had to deal with slide just previous to that one. Yeah, there we go. On the differentiate funding between startup and annual operations. You agree, oh, I'm sorry, the next one. Create a needs-based funding. That one you put disagree on, but you're telling us that you're already working on that.
Right.
So you,
Yeah,
do
it's
you degree or disagree, or what degree do you disagree?
I agree. I agree that we're already working on that. That just
Okay.
wasn't reflected in the report. What I disagree with is that it wasn't reflected in the report, that we were already working on that. But honestly, they would have had no way to know that because that's all in another line item and not
So
what
the
they were
concept-
tasked with.
The concept you agree with, but the the presentation was.
Yeah.
Okay. And then the other one, you put the require Medicaid and private insurance reimbursement. You said that's out of the scope of evaluation. Do you have an objection to looking at that from a legislative point of view?
I would love it. That's what we talked to the staff about. But it's a bigger policy issue than, obviously, than just the crisis centers and the Department of Mental Health.
Okay. So in essence, as far as the 5 recommendations,
Right.
well, it seems like we're fairly unified here, more than a 60% rate.
Yes.
Is
Yes.
that correct?
Correct.
So out of all the comings and goings, it seems like we seem to be headed on the right path.
Sure.
Okay, thank you.
And just one clarification for the require Medicaid and private insurance to reimburse at the emergence rate. That was a recommendation made directly to the governor and the legislature. You should consider these things, understanding that it's out of probably the wheelhouse. And that's what we discussed in our stakeholder work group meeting. So that's where that comes from.
I recognize that. I just want to make sure that the commissioner was okay with
Yeah.
what we were trying to accomplish. Okay.
Absolutely. It was a good discussion we had about it.
Any other questions, comments, reflections? Commissioner, thank you. Thank you for being here today.
No, yeah, I think it, and I'll be quiet, I promise.
Your last time.
My last time I'm recognized. You know, we may want to circle back, you know, if you're agreeing to some of these recommendations that we have, you know, 5 out of the 6, and we're 6 out of the 6, you know, and we're all trying to accomplish the same thing here today. Maybe it's worthwhile putting it on our calendar to look at this again in a couple of years. Just as a quick study, we've already got the foundation done. We know what we're looking for, and maybe might be a lot quicker and easier.
Well, maybe, but I think between now and 2 years from now, I think we're gonna find some other whats that we're gonna be putting into from the requests that I've gotten. So we'll develop that, and then they'll come and complain about me, what I've put in on that, but that's okay.
All right.
Thank you, Commissioner. All right, we're moving along. Is there any old business? No old business. We're moving into new business, the FY26 budget and the proposed FY27 budget request.
Yeah, so you should have a handout in your booklet there that is our typical format there, which shows what we project to end fiscal year 25 with, what we are proposing or what we've kind of issued in the op plan for 26, and then the request for 27, which is level funding. As we've noted in the past, we're working through our rollover funding, and we're digging more into that. We've got more staff now, more consistent staff, so that's going to obviously help do that. So this is what we're proposing, and if there are any questions.
Any questions on the proposed budget? If there are no questions, do we have a motion? And a second? We have a motion and a second. All in favor of the proposed budget, say aye. Opposed, like sign. The proposed budget does move forward with approval. Now moving to the FY27 work plan. Marcus, if you'll go over that.
Yeah, so obviously we sent out the survey to the members. What are your top 3 priorities? We received the feedback, and then we scored those based on, you know, top priority and whatnot. The 3 receiving the most popularity, I guess, are the state court backlogs, and that's through the Administrative Office of Courts. Social worker retention rates, looking into that and what can be done about that, and then the Department of Early Childhood Education, first class pre-K. Those were the top 3. The other kind of tiers to consider are down below, and you have that in front of you. Do want to make it clear that we still are in the midst of a charter school evaluation. And we have on our work plan from last year the electronic monitoring within the Bureau of Pardons and Paroles. So this would be in addition to this work plan would be in addition to wrapping up those other things that we have working on right now. So, and I believe, Patrick, you have something you wanted to add or speak to about this?
I'm just here, I enjoyed meeting with all of y'all to develop these topics and the evaluation plan, and I'm here to answer any questions about the specifics, but like Marcus said, we could easily focus on these next three, along with the ongoing evaluations that we have. And then something we did this year that y'all asked us for is the evaluations that weren't necessarily deep dives that we gave you an update on the previous meeting. We have a couple more updates on those coming to you in the next month, hopefully. So we could start that same process with those that were tied for fourth in the voting.
Any thoughts?
I've got one.
Sure.
The top one listing here, the AOC and state court backlogs and such. With the new Supreme Court justice taking office in January, I think she's already moving forward with trying to do some things along that way. So my suggestion would be we consider hold off doing this, giving her some time to take a look at things herself before we try to jump in and start more, especially if we've got two others that were going along. Let's give this one a breather and give it some time to sort out some first. That's my thoughts.
Fair enough. So we are looking here at the social worker retention and the Department of Early Childhood Education first class pre-K. Any objections? Want to vote?
Yeah.
All right, so we will have a vote. Obviously, those are the two proposals for the 26 work plan. Do we have a motion? So moved. Kathy is a motion. Do we have a second? I'll second. Doreen is our second. All in favor, say aye. Opposed, like sign. The motion certainly carries. If there is no other business to come before this group today, do we have a motion to adjourn?
So moved.
All in favor, please stand up. Thank you for coming. We appreciate it.
Appreciate you. Thank you. Yeah, I think so. I think so. Yep. It's not necessary, but we can get into some of the things that we blatantly disagree with their response to. But I think we've all discussed it, and we're just going to move on. Okay.